Good morning, everyone. Welcome. Whew, it's cold out there. To the Global Health Grand Rounds and emerging infections and outbreak control. Ebola, do you remember? It's fun every time. Okay. I'm glad you're here. My name's Mike Davis. I'm an infectious disease doctor, and I get to direct the Center for Global and Community Health. And this morning, I get an opportunity to talk to you about some emerging infections, set some understanding, some principles of emerging infections, and also teach you some ideas about outbreak control and infection transmission in healthcare settings. And this is something that is important in the world at large and also important in the world at Erlanger as we prevent the transmission of these infectious agents. So it'll be a little bit of everything. And we'll go also a little bit into emerging infectious diseases, which is one of the most fascinating fields in medicine because it comes and it goes and evolves and changes. It's always interesting. All right, so 3 goals. Describe isolation precautions for contact droplet, airborne, and hemorrhagic fever precautions, and according to the organism. So it's the organism's size, how big it is, its stickiness, which is a term I made up for how much of an infectious dose is required to cause an illness, and its scariness, because we do different things depending on how scary this germ is, like this, okay? And then we'll talk about, I will show a cool map of various emerging infectious diseases and talk about them in the context of what type of precautions are required. Okay. We'll talk just a little bit about the Ebola response also and some ongoing work in viral hemorrhagic fevers. It's an exciting time to work in that field. I have no financial relationships to disclose. I will not be discussing off-label use depending on how you define the labeling for agents for hemorrhagic fever viruses, okay? Okay, back to the game plan. Conceptual emerging infectious diseases, framework for infection prevention, level of precautions. It's a pyramid. I've taught you things in the past, you know I like to think of things in terms of a pyramid. This one goes from the hemorrhagic fever virus, PPE, down to hand washing, and I would be remiss as an infectious disease doctor if I did not talk to you about hand washing every time. The S's, the size of the organism, the stickiness or the infectious dose, and the scariness. And we'll do some cases along the way. All right, so this is an awesome example of global emerging and re-emerging infectious diseases. This is a map that's published by the CDC annually. This is the 2017 map. And if you can overlay, if you have been in an airplane lately, you can overlay some of those flight maps that the airlines put out there. If they had like loopy lines instead of straight lines, you could see a lot of the same connections. But we're gonna see this map maybe 5 times in the next 30 minutes. And we're gonna discuss some of these specific organisms that are emerging and re-emerging, and some of the concepts of emerging infectious diseases. Because as human beings interact with our environment and the microbial life inside of it, infectious diseases will emerge, especially related to climate change and habitat destruction, and also will re-emerge as we lose. In the news this past week there were an outbreak of pox viruses, and that the reemergence of pox viruses often has to do with the fact that people don't vaccinate for smallpox anymore. So anyways, fascinating field in medicine. We'll try to illustrate some specific examples, and then we'll discuss this pyramid, okay? So at the top of the PPE pyramid is the Ebola gear, and we'll discuss a little bit about what are the features to prevent transmission of hemorrhagic fever viruses. Then we'll go down to things that are more common and everyday for you guys, contact gowns and gloves, and how that plays into emerging infections in the developing world. We'll talk a little bit about masks and what they're designed to prevent the transmission of, down to standard precaution, hand hygiene. We'll talk a little bit about bed nets and vector-borne illnesses because they are emerging and re-emerging. This is a standard PPE slide that you would see in an infection control presentation at Erlanger or any other facility that you work in. We tend to use transmission-based precautions depending on those S's that I told you about. I'll not be describing to you in kilodaltons the various weight of these infectious organisms because your eyes would glaze over like this and you would fall over asleep. But this is one of those topics that's probably easier just to memorize what goes into what category, okay? Contact precautions, droplets, and airbornes. A little bit more just data about PPE itself. Not only does it matter what you use, it matters how you use it. And we have, the folks here have a nice protocol for the way they don and doff their personal protective equipment for hemorrhagic fever viruses. And we have to go through these trainings and retrainings over and over again so you get muscle memory so that when you're tired or when you've seen, when you're scared, it's a process that you can still go through. Okay, so here is our first case. And someday I'm going to have an audience response system in here that you guys will respond to. We're not there yet. But here's the patient. His name is Gilbert Chepkwony. And this is June of 2014. Think back to June of 2014. What were you doing then? Okay, I was in Africa then. And this is what I was worried about. He's got headache, hotness of body, which is the way that fever is described in the place where we live. Dysentery. He's a 44-year-old mining executive. He comes to the clinic with 48 hours of symptoms, 2 weeks after returning from Sierra Leone. This is your physical examination of Gilbert. And this is the question. What kind of precautions should you use? Who thinks A, this is typhoid fever, contact precautions? Who thinks B, this is Ebola virus disease, hemorrhagic fever precautions? See, if you guys move, then it means you're listening. This is TB, this is malaria, and I don't know. Okay. That thing's really hot without that little thing on the pack on the back. Whew. Okay. So on our map, these are some of the emerging and re-emerging infectious disease for which we require Ebola gear level of PPE. And they tend to center in Central Africa. That's where a lot of the cool viruses in the world come from, okay? And there's also one that is up in here, the Crimean Congo hemorrhagic fever, that has emerged over the early 2018, which is a little, but these are the ones where they come from, largely Central Africa, Lassa fever, Marburg, and Ebola virus are sort of a grouped hemorrhagic fever. Okay? So here's one of the case definitions. This is from the Kenyan Ministry of Health. A fever of acute onset plus one or more of the following: vomiting, diarrhea, abdominal pain, headache, sore throat, measles-like rash, red eyes, and bleeding from body openings. So these are not really rare symptom complexes. And the key that I want you to try to take home in this, from this slide is that you really have to have the epidemiologic risk. You know how you click on travel history and the admission processes at Erlanger, and you just like roll your eyes at that thing? I understand, okay? I understand. It's largely a wasted piece of your effort at this point. But if you're in this context and you're worried about hemorrhagic fever, this is a very nonspecific symptom complex, except for bleeding from orifices, okay? If you get to bleeding from orifices, everybody's going to make this diagnosis. But the transmission risk is primarily early in the clinical syndrome when you have these. You know, you could sit in the clinic where we were in Kenya and have 10 patients in the morning that fit the initial fever, vomiting, diarrhea, abdominal pain, headache, sore throat syndromic complex. And if you don't know that they had this specific exposure risk, then you're going to miss this diagnosis. And this is how it was missed in the U.S. in 3 of the 4 cases. This is some of the CDC output on characteristics of Ebola virus disease for healthcare workers. It is a exposure risk of mucous membrane and respiratory tract exposure. The incubation period in clinical Ebola virus disease is 2 to 19 days. In some body sites, the risk of having live virus goes into around 100 days. The clinical syndrome findings are the same as described by the Kenya Ministry of Health. Diagnosis has been historically made by an RT-PCR, though they're developing now rapid antigen screening tests for Ebola virus disease, which will change things in a lot of ways. We'll talk a little bit about some of the more recent developments in hemorrhagic fever viruses. Infectivity is person-to-person transmission through unprotected contact with blood and bodily fluids, percutaneous injuries, and there is risk of sexual transmission as well. This was a talk I gave to some of the ophthalmologic colleagues who are working in post-Ebola virus disease. This is an interesting brief report from the New England Journal from 2017 looking at persistence of the virus in ocular fluid. And these were some of the places which can still be have infectious Ebola virus recovered in the ocular fluid up to 98 days after clinical resolution of symptoms. So this is something that we learned in 2014. Ebola virus has been around for millennia, and we learned more about it in the 6 months from April to October of 2014 than we've learned about it in all of the time before then. The testicular tissue can have infectious virus up to 82 days, and there is some risk of CSF infectious fluid up to 10 months. Okay. How many of you knew that there's an ongoing outbreak of Ebola virus disease right now? All right. So about half my crew. It started on August 1st in eastern Congo in a place called Kivu. And as of Tuesday, had a total of 513 suspected cases, 379 confirmed, and 245 deaths. The response to hemorrhagic fever outbreaks has really changed a lot in the last 5 years. And I want to share just a little bit with you about some of the new tools in the Ebola arsenal. This was a perspectives piece that was published in October in the New England Journal. There are just a lot of new things that have come out since that initial outbreak. There are 5 therapeutic agents that are now in and have been approved for compassionate use for Ebola virus disease. 3 antibody type agents like the ZMapp that was used on the physician who returned to the U.S. with Ebola virus disease. There are 2 direct-acting antiviral agents that have been developed and are in compassionate use and in therapeutic trials in eastern Congo. And then there's a recombinant glycoprotein vaccine that's being used in an expanded use protocol within this particular outbreak in Kivu. And so this is a rapid and aggressive response that has really come along in response to the initial outbreak that got our attention in 2014. There are some novel ETUs, like this guy here is participating in the care of a patient with active EVD, Ebola virus disease, and they're sort of single patient cocoon-like things. You stick your arms into these plastic sheetings, and this guy who's talking on his cell phone and taking care of someone with Ebola virus disease at the same time. For those patients who can stand and move around, it radically reduces the risk of transmission to healthcare workers. Putting on and taking off this gear is really complicated, more complicated than you would think, and really difficult to do perfectly over and over again in the types of environments in which you have hemorrhagic fever outbreaks. This is a really exciting new development in the response. We need one of these here. Yeah, okay. Case number 2. Chepkwony has loose motions and diarrhea. He's an 8-year-old boy. The time is late in the dry season. He has 4 days of watery diarrhea, greater than 10 episodes per day. He's unable to take anything by mouth. His exam is afebrile. His heart rate is 133. He has a lowish blood pressure and is a little tachypnic. Generally he's ill-appearing. He's sitting in a pool of watery diarrhea. His abdomen is soft and non-tender. What kind of precautions should you use? Who thinks A, this is cholera? Contact precautions. Yes. Who thinks B, this is Ebola virus disease? Ebola precautions. Or I'm not sure and I'm scared enough and I'm going to go ahead and put it on. Okay, who thinks C, this is tuberculosis? Airborne precautions. Who thinks D, this is malaria? Standard precautions. Who thinks E, I don't know. All right, so here's from the WHO. This is some of the PPE to use in cholera outbreaks. The Vibrio cholerae is a anaerobic gram-negative rod, and unless you have been to a cholera outbreak, you do not understand how much stool is really involved in an active cholera outbreak. We're talking like 10, 15 liters a day. So the reason that the WHO recommends contact precautions in a cholera outbreak is because there's a huge volume of infectious material and it's almost impossible to keep yourself from becoming contaminated. So in a lot of parts of the world where you have cholera outbreaks, you don't have these fancy blue gowns like this one that we could take on and put off, but they tend to use any sort of, what do they call it? Hold on a second. Clean, non-sterile, long-sleeved gown. It's just to keep stuff off of you, okay? But another feature I wanted to highlight in this particular case is seasonal epidemiology. So how many of you guys are from a place that has a dry season and a wet season? A few of you. Okay. So people who live in all of their life in temperate climates don't necessarily understand that when you have the dry season, you're going to have different risks epidemiologically than when you have the wet season. All right? And so these are two pictures from the same place in the dry season and in the wet season. And this is a really cool article from the American Journal of Tropical Medicine and Hygiene on the impact of rainfall on diarrheal disease risks in places with unimproved water and sanitation. For when we were taking care of patients in Africa, there was, so the solution to pollution is dilution, okay? So in a time of the year where you have very little water, the concentration of these infectious organisms goes up, and then there's just a cycle of challenge where you have voluminous diarrhea with highly infectious organism burdens in a water environment that's highly restricted. So these are the agents in the emerging and re-emerging infectious disease world that require contactee precautions. And these are the ones that we do with up here: carbapenem-resistant Enterobacteriaceae, the MRSA, cholera. This little line goes up to Haiti, and this one, and it goes over here to some places in Southeast Asia where they're having quite a bit of cholera, and then Yemen. It should go to Yemen, but it doesn't. Okay, typhoid fever, diphtheria also are contact precautions. All right, next case. Return of Gilbert Chepkwony. This patient has fever, generalized body weakness, and dry cough. He's a 43-year-old man who has HIV. He's on abacavir 3-TC, atazanavir, ritonavir, presents at the end of the dry season with 4 weeks of fever, episodic with weight loss. He's adherent to his ARVs. He's febrile. He has diffuse lymphadenopathy, chest clear, abdomen soft. Here are his other data. His white count is 8.8. His normal diff, his hemoglobin is 11, platelets 188. His CD4 3 months ago was 128. His viral load is undetectable. He has an abnormal chest X-ray, AB normal. Okay, What kind of precautions do you use? A, this is community-acquired pneumonia, standard precautions. B, this is pneumocystis pneumonia, also standard precautions. C, this is tuberculosis, airborne precautions. D, this is influenza, droplet precautions. E, I don't know. All right. Here is a slide from your friends at the Center for Disease Control. And this is the table that looks at respiratory infections and their precaution list. So ones that you would expect, MTB gets these airborne precautions, some of these emerging coronaviruses, and they're all coronaviruses. Also use airborne precautions. And then for other respiratory viruses, we'll get into droplet precautions in just a moment. Some of the rash-related precautions for petechial ecchymotic rash and fever in areas, especially that are endemic for Neisseria, use droplet precautions consistent with routine bacterial meningitis droplet precautions. Ebola virus disease we talked about, varicella zoster that crosses more than one dermatome, also gets airborne precautions, and measles. Measles. Don't forget things about measles because it's going to come back up. And it is. Oh, look, here it is. Measles. It's in California. All right? Measles is one of the world's most infectious diseases. And children die of measles. I've seen it. MDR, XDR tuberculosis is the kind of thing that keeps an infectious disease doctor awake at night, fearful for drug resistance development in tuberculosis. This Middle Eastern respiratory coronavirus and SARS are also airborne precautions, emerging infectious diseases. The viral reassortment that goes on around these coronaviruses is really fascinating, but it also tends to cause highly pathogenic strains of organisms when you end up being in really close contact with birds or camels or swine. So that's why the infectious disease doctor only eats deep-fried food. Just kidding. Okay, next. This is our patient. He's got cough, fever, and congestion. He's a 36-year-old visiting physician from the U.S. He has 3 days of symptoms immediately on arrival. He doesn't get his influenza vaccine because I never get sick. And I once got the flu from the vaccine. This is your physical exam. Okay. What kind of precautions should you use? Number one, this is community-acquired pneumonia, standard precautions. B, this is pneumocystis, standard precautions. I hope not. C is TB. D, this is influenza, droplet precautions. E, you should make influenza vaccination requirement for all visitors. You guys, if you're going anywhere with us, you're going to have a flu vaccine. And if you choose not to, you can read this great book called The Great Influenza. When you have time to read 1,000 pages on the 1918 pandemic. 1718? Whew, fascinating. Okay. Here are the droplet precautions emerging infectious diseases. H3N2 influenza, H1N1 influenza, these adenoviruses, and anthracosis that's aerosolized. Hopefully that never comes around. This is the only one that's, quote, deliberately emerging and centered here in Washington, D.C. This is not supposed to be there. MERS-CoV is airborne virus. If you ever really want to know where cool influenza comes from, study it in China. H5N1, H7N9, H1N8, and then the plague. Plague tends to be presently primarily coming out of Madagascar. Madagascar is a great place for the plague. Okay. All right. Okay, just a little bit on vector-borne infections. And these are my kids, so I can make this kind of joke about them. There's my wife's here. Our kids. This is our Annie girl. This is one way you can get vector-borne infections is by going to eating in places that have lines and serve yourself. Okay. Who can name that mosquito? This is another one of those fun infectious disease things. Okay. There are three primary agents of infectious transmission of arboviruses. Anybody want to know what this one is? God, Anopheles. We got some mosquito people here. How about this one? That's Aedes. What about this one? Culex. Well done, team. Okay. Vector-borne infections are emerging in the developing world, both the arboviruses and new and more resistant strains of malaria. These are your primary prevention measures, and others. But bed nets is a key intervention to prevent the transmission. These tend to come out of Central South America. Some of the arboviruses that they're making their way all along the mosquito belt, which runs around right through here. Drug-resistant malaria, if you ever want to study or are interested in drug-resistant malaria, there's a little place on the Laos, Cambodia, Thailand border. I think we're going to try and visit that in February, where all of the drug resistance and artemisinin and resistance to malaria comes from. It's super, super awesome. Okay. Next, and getting toward the end, what is the most important personal protective equipment? Hand hygiene. There is no other answer. All right. This is what is called the water of the foreigner in Swahili, Maji Mzungu. And so the routine and consistent application of hand hygiene is the most effective means to prevent transmission of any infectious diseases. If I didn't give you guys a little push in that direction, I would hope to. One of these days I'm going to do this surveillance project where I look at how often you guys wash your hands in and out. I think you're pretty good at it, actually, you guys who work for me. And but I think this is something, if we don't go over it consistently and without fail, we'll forget it. Okay, so here is sort of a summary slide on the various types of local precautionary measures. So you can take these principles for the size of the organism, the stickiness or the infectious dose, transmissibility, and the scariness of the organisms, and translate that knowledge into what type of precautions do you want to use when you're suspecting these infections. Contact precautions in our areas are MRSA and active wounds, not on the nose. C. diff, which has its own little unique thing. Lice and scabies, don't forget lice and scabies. Okay? Droplet precautions in our patient population would be respiratory viruses suspected of influenza. We've had a pretty easy season so far, but it tends to peak up in this area right after Christmas, the first of the year. And then suspected bacterial meningitis. All of your bacterial meningitis pathogens come up your nose and into your brain. So that's why I use droplet precautions for those first 48 hours after you've started administering antibiotics. Airborne precautions here tends to be largely suspected pulmonary tuberculosis. N95 rooms are available in this facility. You should have a fit tested N95 mask and beware of your beards in the wintertime. Okay. Also, multidermatomal zoster. That's the other one that's commonly found here. So I've gone through this pyramid with you from Ebola gear hemorrhagic fever virus, protection through contact gowns and gloves, N95s, surgical masks, and face shields I did not talk to you about too much, but face shields are very useful, especially when we don't do a whole lot of invasive procedures or intubating, but when you do, it's easy to get things coughed into your eyes and mouth, and then especially in highly transmissible viral infections, it's easy to acquire. Keep that in mind. And then standard precautions, hand hygienes, and bed nets. So here's our summary statement. Infectious diseases are continuing and will continue to emerge and reemerge. We can understand some things about how to protect ourselves and how to prevent transmission patient to patient through understanding the S's and the appropriate use of personal protective equipment. This is my email address, and this is the end of the show. Thank you. Okay. Dr. Dr. Sweets.
So we recently had a patient in the medical intensive care unit who there was an upper lobe cavitary lesion. There was some small concern for tuberculosis, and we put the patient in a airborne precautions room, which we subsequently found out did not have a working fan, and then had to move the patient next door. And just wanted to ask your knowledge of the adequacy of our current, infection control regarding negative pressure ventilation, and which rooms in the hospital have negative pressure ventilation.
Usually ones that end in 14. 7114, or not 71, yeah, 7114, 8114, 9114 have functional negative pressure isolation. Sometimes in the units, there's some variability. But I would defer to my infection control colleagues and also encourage you wear your N95 mask. People get out of N95 jail when they have negative smears, and those are at our institution sent off to Birmingham, Alabama to be smeared, and it takes multiple telephone calls to the micro lab to get people out of those precautions. Your pretest probability for tuberculosis is driven by your epidemiologic risk factors and your immunosuppression. The vast majority of the people we test are negative, but it doesn't mean we don't need to test them or that we don't need to be careful. Okay? Dr. Hyde.
So, thank you for that. It was a brilliant review of stuff. We don't see tons of stuff that we do. You mentioned getting out of contact precaution jail. There's a lot of misunderstanding about how long certain contact precautions are relevant, particularly for things you see often like C. diff and then meningitis. You touched on that just really quickly.
Yes, that's a bit of political realm statement in our institution because there's not a lot of data to support the discontinuation of PPE for infectious agents. There is a guideline that the IDSA and the group called SHEA, who are super cool, the Society of Hospital Epidemiologists, and they have guidelines for discontinuation for C. diff precautions after the cessation of diarrhea, and for droplet precautions for suspected meningitis, either when it's ruled out, because most of the time we rule it out, or within 48 hours of initiation of antibiotic therapy. That being said, we publish a local algorithm for when we discontinue or continue contact isolation for people who are colonized or infected with multi-drug resistant organisms, and we just go by what the infection control standards say. So if you have a question, just call the infection control people, and they'll tell you this is our hospital standard policy for this. Other questions, comments? Thank you, guys. I hope you have a great day. Go ahead and eat some more of my breakfast, and wash your hands.
You ladies for coming.